Welcome to Nurse Practitioner Week. The presenter for this session is Lisa Chappell, PhD and FMP. Dr. Chappell is the Associate Dean of Family Nursing at Frontier Nursing University since 2014. She has worked as faculty at Frontier since January of 2009. She's been a nurse for 40 years, including 20 years as a family nurse practitioner. She obtained a Bachelor of Science in Nursing from Auburn University, a Master of Science in Nursing from the University of Alabama in Birmingham, is a maternal infant nurse specialist, and a second MSN as a family nurse practitioner. She earned her PhD in nursing from the Medical College of Georgia in 2007. Dr. Chappell's clinical practice experience as a nurse practitioner includes rural clinics, emergency medicine, student health, a psychiatric facility, and correctional medicine. Dr. Chappell has 17 years of teaching experience, mostly at the graduate level with nurse practitioners.
Welcome to Frontier Nursing University's virtual event for National Nurse Practitioner Week. The event is a mission-focused with nurse practitioners answering the call. I'm Dr. Lisa Chappell. I am the Associate Dean of Family Nursing at Frontier Nursing University, and I've been a family nurse practitioner for 22 years. Today, I'd like to talk about health disparities in African American men as illustrated by male prisoners. The objectives of this presentation is to present a review of health disparities for African American men. We'll use case studies to illustrate health disparities in a male population of inmates, and then we'll have a discussion of awareness and possible approaches to health disparities. And just a little bit about my background and how I became interested in men's health. At my very first nursing position, which now has been over 40 years ago, was on a urology floor. So we had patients with all sorts of problems, male patients with all sorts of problems, from a TURP to injuries or infections. And really, I became interested in male health problems here. When I became a family nurse practitioner, I realized what a part nurse practitioners can take in addressing men's health, and particularly minority men's health. One of my longest positions as a nurse practitioner was in an emergency room where we saw a variety of male patients with health problems, minor injuries, minor illnesses, all the way up to acute illness or acute injuries. My PhD dissertation had a component of health disparities for African American women, and prior to coming to teach at Frontier Nursing University, I worked in a male prison with 4,100 male inmates, and this is a setting where I became acutely aware of issues in men's health, particularly in minority men's health. Let's take a minute and look at the leading causes of death for African American men, and I'm just going to read these to you so we don't miss any. Number 1 is heart disease. Number 2 is cancer. 3, stroke. 4, diabetes. 5, unintentional injury. 6, chronic lower respiratory disease. 7, homicide. 8, septicemia. And 9, Alzheimer's disease. These statistics are from the CDC. And let's look at a couple of the different health problems that we'll find in men, and particularly how the African American male compares to the non-Hispanic white male. African American adults are 40% more likely to have high blood pressure, and they're half as likely to have their blood pressure under control. So 40% more likely, and only half will have their blood pressure under control. Coronary heart disease among persons 18 years of age and older, the non-Hispanic black 7.0, non-Hispanic white 6.3. Heart disease death rates per 100,000 for the non-Hispanic black is 286.3, non-Hispanic white is 226.9. Percent of people 20 years of age and older who have high blood pressure, non-Hispanic white blacks 40.5, non-Hispanic whites 31.1. So you'll see in all of these measures, the African American male fares worse than their counterpart, the white male, and only half of these will have their blood pressure truly under control. This slide shows cancers comparing African American men to non-Hispanic white men. All sites, the rate is for African American men is 610.4 versus for white male 558.9. A couple of interesting things about this chart is on every measure, African American men fare worse except for oral cavity and pharynx cancer. For African American men, it's 14.9 versus the white male is 18. A couple of really concerning facts on this. Look at the prostate cancer rate. For African American men, it's 228.5 versus 148.2 for white males. Also look at the stomach cancer rate. It's double for African American men, 16.1 to 8.3 for white males. So on every measure, African American men are going to fare either equal to or worse than their counterparts, except for oral cavity and pharynx cancer. Strokes in African American men, the percentage of strokes among persons 18 years of age and older for non-Hispanic blacks is 4.5, non-Hispanic whites is 2.2. The stroke death rates per 100,000 for non-Hispanic blacks is 58.1, non-Hispanic whites 37.5. So there'll be higher stroke rates among African Americans, and there'll be higher percent of death among African Americans for strokes when compared to their counterpart. Diabetes in African American men, the percentage of people aged 20 or older with diagnosed diabetes. For non-Hispanic black, it's 13.2, non-Hispanic white, it's 7.6. And every time I see that word diagnosed, I always wonder how many are there that are undiagnosed, that either haven't been for health care, haven't developed the problems that would send them to health care, or haven't been tested if they've been in health care. So how many are out there undiagnosed? We also know that African Americans are about 3.5 times more likely to develop end-stage renal disease than whites. So more frequent diabetes and a really high percent will develop end-stage renal disease when compared with their white counterparts. Cigarette smoking, the percent of persons 18 age of older who are current cigarette smoking, for non-Hispanic blacks, it's 24.3. For non-Hispanic whites, it's 23.2. So pretty much the same rate of smoking, but more concerning is, do we address quitting smoking when we have the smokers in the clinic? This statistic says that we do not address the African American smoker like we do white. So this says percentage of current smokers age 18 and over who are in a checkup and who report receiving advice to quit smoking. Non-Hispanic blacks is 59, while white are 66. So African Americans receive less counseling to stop smoking. And then COPD in African American men. The prevalence rate for COPD, let's look at chronic bronchitis. For African Americans, it's 38.6. For whites, it's 50.8. For emphysema, African Americans is 8.1, where whites are 21. So African Americans do have chronic bronchitis and emphysema at lower rates than their white counterparts. The death rates for COPD for African American men is 37.7. For white men, it's 50.5. So in this particular instance, African Americans do fare better than their counterparts. And then Alzheimer's disease. The Alzheimer's Association says that Alzheimer's is more prevalent among African Americans than among whites, with estimates ranging from 14% to almost 100% higher. A gene mutation has been identified, gene ABCA7, that nearly doubles the risk for African Americans. Those statistics are pretty alarming to me and very concerning because, as you probably know, the fastest growing population in the United States are the elderly. And by the year 2050, I believe we're going to be at 83.7 million people over 65 years or older. And that's a tremendous growth in those numbers. And how many of those will be in this category? So let's look at some case studies from male inmates. Please know that all identifying information has been removed. Anything that I say that is a descriptor has been changed so that for the protection of the patients. Mr. M. Mr. M was a 42-year-old black male with a chief complaint of feeling short of breath when walking the yard. His past medical history, he had a history of hypertension that he was told years ago he has been on no meds for decades for hypertension. Family history, his father's decreased due to stroke at age 60, mother's still alive, age 75, has hypertension and diabetes. On physical exam, this was a well-nourished, well-developed black man in no acute distress. He was alert, cooperative, heart rate 88, respiratory rate 20, blood pressure 160 over 110. So we see that today he is hypertensive. Cardiovascular, he had an irregular rhythm. S1 and S2 were identified, but no murmur or S3 were heard. Pulmonary, he had coarse breath sounds, but no wheezing or crackles. Lower extremities, he did have 2+ edema in both lower legs and ankles. We were able to get a chest x-ray on Mr. M, and it showed a boot-shaped heart. And you'll know that a boot-shaped heart is indicative of left ventricular hypertrophy, which is one of the consequences of decades of uncontrolled hypertension. So he did have a pretty enlarged heart that could not do the work when he exerted himself, even by just simply walking any distance. Our plan, we ordered, gave him HCTZ. We talked to him about a no added salt diet, recommended that he does have short periods of exercise as he can tolerate it, asked him to return to see us in 1 week or sooner, reevaluate his blood pressure, evaluate his renal function, CBC, BNP, and do an EKG, and then consider starting an ACE inhibitor or calcium channel blocker for his hypertension. So Mr. M was going to need ongoing care for management of his hypertension. The left ventricular hypertrophy was a really serious condition to try and treat in the prison setting. A second patient, Mr. B. Mr. B was a 53-year-old black male with chief complaint of cough. His cough had persisted 3 to 4 weeks. He now has shortness of breath when he coughs. Past medical history, no known health problems. He was a smoker for 40 years, smoking 1.5 to 2 packs a day. Both parents were deceased of unknown causes. He had 1 living sibling, a brother with hypertension. On physical exam, he was well nourished but thin black male and no acute distress. He was alert and cooperative, heart rate 80, respiratory rate 22, blood pressure 140 over 90. Even Mr. B is slightly hypertensive. Cardiovascular, he had regular rate and rhythm, S1 and S2 identified, no murmur. Pulmonary, he had coarse breath sounds throughout. And you'll know that for someone who has smoked a long period of time, they will have coarse breath sounds normally. Also, Mr. B had decreased breath sounds in the right mid and lower lobe. Abdomen was soft, positive bowel sounds, no messes or tenderness. We were able to get a chest x-ray on Mr. B, and he had a star-shaped lesion in his right middle lobe. And you'll know that a descriptor such as star-shaped or stellar usually is indicative of some type of malignancy. We followed up with lab work, CBC, metabolic panel, EKG. We were able to get him out for a CAT scan, and he was to return to see us after the CAT scan. The CAT scan did identify that stellar-shaped lesion, and he did have malignant lung cancer, a malignancy in lung cancer. And so my question about Mr. B is, had anyone ever talked to him about not smoking? Had anyone ever talked to him about quitting smoking, or any advice to cut back and the consequences of long-term smoking? And then our third patient is Mr. G. Mr. G is a 48-year-old black man with chief complaint of knot in his groin. He says he's had a hard knot there for about 4 to 6 weeks. Past medical history, he is hypertensive. Family history, father not known, mother was living, age 73, with hypertension and type 2 diabetes. On physical exam, he was a white, well-nourished, thin black male and no acute distress. He was alert and cooperative, vital signs 80, respiratory rate 18, blood pressure 150/86. He's hypertensive too. He has cardiovascular, regular rate and rhythm, S1 and S2. Pulmonary, he did have coarse breath sounds, but no wheezing or decreased breath sounds. Abdomen was soft, no masses, positive bowel sounds, no tenderness either. GU, he did have a 5-centimeter hard, non-tender lymph node in his right groin. Penis without lesions or redness. On his rectal exam, the sphincter muscle had good tone. There were no hemorrhoids. Prostate exam, it was hard, non-tender, diffuse masses were palpated, and his hemoglobin was negative. So you can probably guess what his diagnosis was. It was metastatic prostate cancer. We followed up with a UA, a PSA, and we referred him out to a urologist for ultrasound and a prostate biopsy. So he is really illustration of that very high rate of prostate cancer in the African American man. So my question for myself and for you is, are there solutions to health disparities? What can we do as advanced practice nurses to address it? We all have a part in addressing, being aware, and acting on health disparities. So after a lot of thought, one of the things that I decided to do in my clinical practice was, when I have that minority patient in the room with me, I'm going to do a very thorough history and physical exam. So I would collect a detailed history, history of present illness, past medical history, family history, a very good social history, a risk assessment, and substance use. Assess for any depression, review all medications, and take a look at their immunization status. And then a complete physical exam. When you have this patient in the exam room, take advantage of their presence there to collect as much data and do as thorough of a physical exam as possible. So physical exam, the skin assessment needs to be all surfaces of the skin, front and back, back of the legs, back of the thighs, the feet, the soles of the feet, and scalp. So look at all of the skin. For ENT, a good otoscopic exam, an internal and external eye exam, and a thorough oral exam. Take your tongue blade and really open up and look at all surfaces of the buccal mucosa, the gums, under the tongue. For cardiovascular system, evaluate the blood pressure, check the peripheral pulses, listen to all 4 cardiac sites, and you're really listening for any extra heart sounds or murmurs. When you do the respiratory assessment, listen to all fields of the lung, comparing left to right, back and forth. Abdominal exam, are there bowel sounds? Do you palpate masses or elicit any tenderness with palpation? And then for the GU exam, are there signs of infection? Are there hernias present? And then do the prostate exam. Really, really important to do this exam when you have the patient with you. And then a musculoskeletal exam. Do a good range of motion. Is there any weakness or pain with range of motion? And these are my references. I'll be happy to share them with you if you would send me an email, or the slides themselves. So I hope that you've enjoyed this presentation. I hope you've learned a little bit about health disparities, particularly in minorities and African American men. And think about what's your place, what's your challenge to help deal with health disparities. Thank you.